but welcome to NGPS's annual general meeting in these strange and profound times, holding it through a Teams meeting, but nonetheless it's a great pleasure to see those of you who've been able to join us, and I very much appreciate the fact that people have had busy days. There is a lot going on at the moment. When isn't there a lot going on? But there is particularly at the moment there's a lot happening, so very much appreciate you taking the time out to join in our meeting, and hopefully we'll be able to provide you with some useful updates, and we'll be happy to answer questions at the end if we're able to. I'm joined in this triumvirate by my colleagues Anthony, our chair, and Rebecca, our chief operating officer, and we'll just spend the first 15 minutes or so just going through a short presentation and then offering the opportunity to answer any questions. And of course we've also got our directors on the call, and we're also extremely welcome, and thank you for taking the time to join us on the call to our directors. Before I start, just some notes on housekeeping, if I may. The meeting is being recorded, so I hope that you'll be able to shout from the rooftops at the end of this when you've had a splendid meeting, and encourage those who weren't able to join us at the meeting to let them know that the meeting is actually being recorded, so that they can dial into that and choose to watch the nuggets, golden nuggets on display. If you have got any questions, if you can please put them in the chat and use the chat function, and then we'll then invite people to answer those specific questions. And can you also please stay on mute unless you're asked to unmute to ask a particular question. Just a final thing before I move on to the body of the presentation. Our annual report, which has been drawn up by Kate, our fantastic comms manager, who is actually facilitating this meeting. So Kate, thank you very much for your support. But our annual report will come out next week, and we'll obviously provide more detail as well in the same format as it did last year. So that's the general welcome over and the housekeeping points, and if I can just move on to my first slide, please. So our mission hasn't changed, and you'll see on there essentially our role as a federation is highlighted in blue, because you're the ones, our members, who are out there doing all that high quality, safe clinical care, and it's where we can provide support to you that we should be focusing our efforts, and that's indeed where we try to make sure that work goes on. So our mission has not changed, and that remains the same as it was 5 or 6 years ago when the Federation was first conceived and drawn up, and it remains relevant and practical now. Next slide, please. I think what would be helpful to see is our steps towards that mission, and I've just put 6 steps on there in terms of putting some flesh on what it is that we do. So make sure that the voice of primary care is heard, and we spent a lot of time, certainly over the last few months and more, ensuring that our members' voices are heard primarily, but we're also working closely, very closely with the networks on that changing NHS landscape, which we're all very aware of, and you guys working at the coalface as we have been in the past, and indeed Anthony continues to do so. It's just making sure that primary care voice is heard, and that means working and standing shoulder to shoulder as organisations. So as NGPS, as a legitimate organisation, standing shoulder to shoulder with the CDs, with the networks, and with the practices to make sure that voice is heard. And the best example I can kind of give from that really is around our engagement with the Joint Delivery Group, which has now been rebranded to be Collaborative Newcastle. And this is where the heart of the decision making and the operational input for health and social care in Newcastle is brought and is being deliberated. And we have been representatives at that meeting for the last at least 3 years when it's gone through its various iterations. It's really important that we ensure that primary care voice is heard, and that the work that our colleagues and our members are doing, because it's so easy for stuff to be done to us as an organisation and as representative member practices. And I always feel that it's important to be in the tent to ensure that you can be there when those decisions are made and you can shape the progress. So the Joint Delivery Group is one of the key areas that we work into, and we meet with them on a weekly basis on the Thursday. And I have the pleasure, along with some of my CD colleagues who are on the call, of attending that meeting. The second point I've got on there is facilitating collaborative and at-scale working. And I suppose the best example of that in terms of collaborative working has been our work on the Urgent Treatment Centre work with colleagues in Newcastle hospitals, the ambulance service and the out-of-hours provider. I'm very conscious that we've not performed as well in this area, and you know as well as I do that the last 7 months have not been easy under any circumstances. What's happened with the extended access and the urgent access to general practice is that the funding has been re-provisioned and moved into the provision of hot services, whether they be visiting or hot sites itself. But we are working very hard as part of that alliance to make sure that we get back on track with that, to make sure that we provide additional appointments and to make sure that we provide that conduit of support. And again, we're working closely with network colleagues to achieve that. Some of the more recent areas of collaborative and at-scale working have been in the recent asylum seekers project, which Anthony will talk about later on. But that's been a fantastic demonstration of at-scale working, working with MERS, with Newcastle hospitals, really supporting those individuals who are most vulnerable and most at risk. And for those of you who weren't aware of it, some 200 plus asylum seekers, some of whom have been in hotels in Newcastle since December, have not been receiving any kind of level of clinical support. And we've been commissioned to provide that support. And that's essentially come in the form of health assessments and registration with general practice, and then ensuring that they get appropriately assigned social prescribers so that they can get their needs met. And that's been a really positive piece of work, and as I say, I will let Anthony talk about that later on. And some of the care home support. So certainly in the early days of COVID, and one of the recent things that the CCG have commissioned us to look at again is to provide some homogenous support into the care homes. And very early on in the COVID crisis, we worked closely with GP colleagues and practice managers to set that service up, which sat alongside the specialist care nursing team and provided direct support. And again, it goes to that moving away from silo working so that we can work hand in glove with other provider organisations across that continuum of healthcare, which is so important to try to deliver that seamless care. My third point on there is being an honest broker for practices. And I hope that you'll agree that wherever we've been able to get engaged, we've tried to provide a difference. We've worked on behalf of our members. Anthony and I and colleagues within our organisation have direct, relevant experience of working at the coalface and know what it's like, and we can be those honest brokers. So in all of our engagement with other organisations, whether they are provider organisations or commissioners, we want to be that honest broker for our membership. The next point I've got on there is about protecting practices, and that's one of the fundamental tenets of federation working was to protect practice income, and we hope that we've done that by providing some additional income support. But there's also reputational support as well, and being again working alongside the LMC and others to try to raise that awareness and protect practices. And we were one of the first to go out to our members to ask them questions about, work pressures and the like, and that was recently followed up by the LMC survey, which certainly makes eye-watering reading for everyone. We are always looking at future projects where we can provide that support in real terms, and we've written up a couple of business cases which will be going out, and that's looking at providing GP support practice nurse support, but more tricky, I think, that admin support. So, you know, trying to lever ways that we can get some additional admin support with professional people who can work in those areas, because as we all know, working with software providers that we've got, whether it's System 1 or EMIS, is not something that you can just get off the shelf. So again, we're working with that. And all of that, we hope, goes somewhere to making the day job easier. And it sounds flat to say it, given that what is going on, and we're all very aware of the work pressures that colleagues within general practice are working under at the moment. But we hope with some of the measures that we've put in place, certainly when I look at the link worker support that's been provided through our manager, Michael Waff, more of him later on, and the individuals working in practice, that it is making the day job easier. And trust me, we are working all the time to try to do that, and that is our raison d'etre. And the last point, before I move on and let Anthony come on to the next set of slides, is be a last resort for our practices. And to that end, 2 practices across the city have come to NGPS to ask for support. Elsick, formerly known as Granger, as you'll be aware, has moved from being a practice which was requiring improvement in a significant number of domains to recently being qualified or classified as good in all domains by its recent CQC inspection. And that's down to the hard work of the practice staff in there, supported by the team at HQ here and by colleagues across the piece, not least of which are working in that inner west area. And it's a real testament, as we've said before, we all knew what the impact of Granger going under would be in that part of the city. The experience of Ponteal and Roe when that closed gave ample demonstration. So it was really important that we worked there. And colleagues in Gosforth have approached us, and as you'll be aware, Avenue Practice recently novated to NGPS, and we are working closely with the team to ensure that we would provide the appropriate levels of support there, both for the patients, but importantly the staff as well. So thank you for your patience listening to me going through my slides there. I'll hand you over to Anthony now, but as I say, we hopefully will be able to, if there are any questions, answer them later on. Thank you.
Thanks very much, Christian, for handing over just when the slides start to get a bit dry. I'm being slightly facetious actually, because this slide contains a lot of information that really emphasises how we've got to where we are and how we've had the successes that we've had. Obviously, our members will know that we're a limited company, limited by shares, but they'll also know that the final 2 remaining practices in Newcastle that hadn't joined the Federation are in the process of going through the legalities of joining, and that, with a memorandum of understanding with West End Family Health, effectively gives us coverage into all 31 practices in Newcastle. Christian's mentioned the contracts that we hold with general practice. And we obviously hold a GMS contract at Avenue. We are actually one of a very small number of federations who's been allowed to novate to hold a GMS contract, and we hold an APMS contract at Elsick Family Practice. A lot of work went in, much thanks to Rebecca early on in the development of the primary care networks, to look at ameliorating the risks of VAT being charged because of network activity. And the fact that we now have a cost sharing group with our network colleagues means that that risk of taxation on network monies has been completely and utterly ameliorated. Very early on, we were an employing authority, so we were able to access the benefits of the NHS superannuation scheme, again something which has set us apart from a number of other federations. I'm going to come on to the last point a little bit later in one of my other slides, but you'll remember that our Articles of Association indicate that our intention is to make less than 10% profit on our turnover, but I'll come on to that in a little bit. If you could move on to our next slide, Kate. Just a couple of slides on the year in numbers. This is self-explanatory. Over the past year, we've managed to increase by about 10% our turnover. I would add that this is completely exclusive of the primary care network monies, which are cared for by NGPS in a separate account for access for the primary care networks. If we could go on to our next slide, Kate. This shows our profit after tax. Actually, there's been a slight amendment to this slide which hasn't come through on this one for 2018-2019, but I'll just explain that in a moment. People who've been with us from early days will remember that initially we made a loss and then relatively very small profits in the first 2 or 3 years, with a significant increase in profits subsequently. 2018-2019, that slide doesn't actually reflect that there was £130,000 dividend paid to practices during that financial year. The actual profit for 1920, bearing in mind our accounts run to January, from January 19 to January 20, we weren't really aware of literally until a couple of weeks ago, but after corporation taxation, that profit is about £426,000. That has, as we as directors recognise, breached that article in the sense that we were hoping to maintain less than 10% profit on our total turnover. But we are looking at projects that Christian has mentioned, particularly about providing significant support with a nursing service into practices. More of those later. They are works in progress at the current time. Have to be remembered as well, I think, that this has occurred over a COVID period when who knows what has happened to everybody's finances, and there have been drains on every organisation, as I'm sure you'll know. Go on to my next slide, Kate, please. Areas of income really include three. The first area is that one that we've been working on over a long period of time, really to look at subcontracting from the trust, for example. I must confess I've always been somewhat disappointed that we haven't been able to expand the number of subcontracts that we've been able to run from the trust, although I assure you it hasn't been through lack of trying. And it seems to me that now, whereby services are going to be coming out into the community, would be an ideal time to continue to do this. I'm disappointed partly because the initial subcontracts that we had were very restrictive in terms of the practices that could access them. And as we've grown to cover essentially the whole of the city with that MOU with West End Family Health, only really sexual health PCNs and the link workers are delivered citywide. The other area, as Christian has already alluded to, is the Urgent Care Alliance, with ourselves working with Vocare, NIAS, NUTH and the CCG to deliver extended access. And we do acknowledge, as Christian has already said, that there have been some frustrations with that as we've moved out of the initial post-COVID phase one. Elsick Family Practice is hopefully increasingly profitable as various services are delivered there, and the workforce is stabilised to move away from the heavy dependence on locums that had effectively crippled it over many years, and with its care of 3 providers. I wanted just to mention the Asylum Seeker project. I think Christian's actually mentioned most of what I was going to say anyway, but we were commissioned at very short notice to provide medical and mental health assessments, together with allowing individuals access into the social prescribing link workers, which we started and completed over a period of about 3 weeks at the Novotel and the Metro Inn in Newcastle. There is a certain input and output of asylum seekers, so about 4 or 5 are leaving per week and about 4 or 5 are coming back in. But we have been approached informally by the CCG to look at recommissioning a certain service running forward, probably for a number of months. Again, this is at an informal stage at the current time. Very interestingly, Greg, who is from Mears, who is providing the welfare support to the asylum seekers at the Novotel and the Metro Inn, received some informal feedback from the government about how well they thought this had run in Newcastle, which we're very proud of, and thanks to all of the team at NGPS, the team at Elsick Family Practice, all of the social prescribing link workers who are putting a lot of effort into supporting those asylum seekers, and to the doctors who've worked into that interesting and rewarding project. This is my final slide, which, oh, no, there was a quick slide in there about statutory notices, actually. We have to put this in as a legal requirement for our AGM. It would include, for example, announcements about which directors were having to resigned from post. Remember, I did that along with Chris Tasker about 2 years ago. But you'd be pleased to know there are no statutory notices to inform you about from today's AGM. Thank you. I'll move on to Rebecca.
Thank you, Anthony. And I've got a little bit of that there, so I'm going to mute the conference room just in case.
Rebecca, you're mute too.
Yeah.
Oh, thanks, folks. I've just got stuck right in the first fail of a Teams call. You're on mute. Apologies. I was saying thank you to Anthony. Thank you to all of you for joining late at night after what I'm sure is another tricky day. We're grateful for your engagement, and I'm going to make this short and I hope positive, because although normally I would happily present the finance, the contracting slides, actually I've got the privilege of ending this presentation on 3 or 4 slides celebrating what our team have done this year. We are so proud of our team, and I'm going to deliver a couple of slides, some facts and figures around what we've achieved. So our team are 12 folks in headquarters. We've got chartered accountants, we've got Kate, who's got two decades communication skills, we've got clinical governance, we've got social prescribers led by Michael, and then we've also got our board of directors who are showing on the slide now, and they're made up of both GPs and practice managers. So we are really proud of the team. We're a cohesive team. We're often in the background, and I just wanted to take this opportunity to share with you who we all are and what we all do. On the note of celebration, we have, as Anthony mentioned, for the first AGM ever, got 100% practice involvement, and we're absolutely over the moon about that. We've got stable leadership. So some of you may know that 2 local chief execs of other feds have recently resigned, and we're lucky enough to have the 2 founding members of the Fed, amongst others, Anthony and Christian, still involved in bringing that wealth of experience to the organisation. And as I've said, we're a cohesive team. Also, for the first AGM, we've got 100% primary care network involvement. Every primary care network in the city is using our services, and again, we're over the moon about that. A couple more points just on celebration. There are other federations out there, there are other organisations out there who don't have the luxury that we do to have a long-term extended access contract and are looking to April with concern, but we don't have that. We're very lucky. We also are very lucky in that we don't have a trust that is overtly looking to vertically integrate primary care, as other parts of the country are experiencing. And again, other parts of the country are experiencing some real issues around the financial viability of their trust and the impact that that's having on them. And our trust is financially strong. And finally, a brief reference to some work that I do with other federations over the country, which in this instance tonight, in this pause for a bit of positivity, allows me to feel a bit smug in relation to our particular position after 12 months as a federation. Another thing that we're really proud of is our stakeholder survey. So we reached out to you in July and August. Not a great time. When is a good time to get an email in your inbox asking you to complete a survey? And we didn't get a huge number of responses. We had in the 40s, about 40 of the stakeholders that we went out to responded. But those that did respond were significantly improved in their positivity and their comfort in us as an organisation than we've had in prior years, and we were again really pleased about that. So a couple of stats just to prove my point. 52% of people felt that we effectively communicated last year, and this year 74% of respondents felt that. And just a big shout out again, and the theme of team, to Kate and everything she's done in relation to the bulletin, the website, the annual report. She can largely take the credit for that stat improving. Engagement, 72% last year felt that they had been engaged with very often, and we're in the 90s this year, so we're over the moon to be hitting these kind of figures, 90s and 80s, in a number of the particular questions. Reputation, again hitting the 90s around positive reputation. And our services went up from 70% to 85%, strongly agreeing confidence in us to deliver our services. There is always still work to be done. We absolutely recognise that. And one of the areas that we want to focus on this coming year is telling you about our plans. 31% said last year that they felt they wanted only knew a moderate amount, and this year it was 52%. So that's an area of focus for us going forward. We couldn't do this presentation without mentioning a glimmer of light in an otherwise pretty dark year, in that Michael, our social prescriber manager, won a national award and gave us all cause for celebration. We're so proud of Michael and everybody, but we felt we wanted to just give him a particular shout out tonight. And that leads me to the last slide, and that's about the future of the Federation and where we want to put our resources going forward. We had a strategy day with our directors a couple of weeks ago, and we outlined, as Christian mentioned, a number of quick win projects that we could start focusing on, and we can talk more about those if you want to. But the most clear message that came out of that strategy day, and that we will be pursuing in 2020-21, is that of collaboration, and specifically collaboration in primary care. So that's our members, that's PCNs, and that's the LMC. And having that collaboration at that level and then going into a wider collaborative environment is going to be our focus going forward. Okay, I'm going to wrap up there. I'm going to invite any questions at all. I'm going to stop my screen from sharing so that we can see the questions, and open the chat box. So feel free to ask us anything. We won't be removing any questions. Please ask us anything, and anything we can answer we will, others we won't take away. So I've got some questions in the chat box coming up. Chris, if I start off with you, and Chris, could I ask you to, could we come to you and ask you to just ask your question out loud, just for everybody to hear? I think this one will be coming at the conference room, Christian and Anthony.
Yeah, just the question is, if we didn't have NGPS looking after the asylum seekers, where would they be looked after? What would happen to them?
I think, can you hear me? I'm not sure I'm on mute.
You're not, we can hear you.
Right. I think, Chris, the answer to that really lies in the fact that the asylum seekers, as I said at the outset, had been basically in the hotels since December. So, you know, they were getting some level of support. Some of them were, so they were getting urgent access, but they weren't really being looked after appropriately. Have contacted us through MEARS just to say that this is an example of collaborative working, is a really positive example, and hopefully we'll take that forward. But the answer to the question is, I don't know who else would do it, but the fact that nobody was doing it from December onwards indicates to me that there wasn't necessarily an appetite out there. I don't know how widely it was known, to be fair, that there were a number of asylum seekers out there who weren't being supported. It was certainly news to me when it came to our attention, but we were, because we've got fairly significant experience in planning skills in terms of medical planning, we were able to respond to it very quickly. And certainly leaning into our colleagues at ELSIC was brilliant, because they provided the ALPS that we needed. I'm not sure if that answers it. I don't know if, Anthony, you've got anything you want to add?
Yeah, I think it would have just been terribly fragmented, wouldn't it, really? And you know, some individuals were registered with practices, you know, but there were all sorts of problems about them not knowing how to get to practices, about not being transported, you know, to and from practices. So it kind of seemed sensible just to deliver a coordinated, quick, you know, thorough assessment from both a sort of medical, psychological, and also a social perspective for these people. But I think the answer is it would have been fragmented, absolutely.
And my point really is that it would have gone to all practices, and they're quite a hard work. So the fact that you've taken them off primary care is actually a benefit to primary care. That's pretty the point I'm trying to get across.
Right, thank you. I agree. Yeah, I agree.
I can see there's a question from Amy there.
Hi.
Amy, do you want to pose the question, or are you happy for me to read it out?
Yeah, no, yeah, I'm just, like you've said, you've acknowledged that the kind of work with regards to the urgent care aspect hasn't performed as well maybe as other areas. And I'm just wondering what's happening at the moment. You know, like we didn't know there was this triage system, even though there'd been people kind of employed to do it for, I don't know how many days it was before we even knew about it. And I'm just wondering kind of what the plans are, because we really need some more support in that area.
Absolutely. So if I can lead on this. So prior to COVID, we were able to provide 80,000 additional appointments across the city, working in the 3 urgent treatment centres and into the walk-in centre at Leamington. Obviously, COVID had a massive impact on that, and CCG took the view that they closed some of the UTCs. So 2 of the UTCs closed, 1 became a communications hub, and it left us with the Pontilla Road UTC to service what had been a much wider availability of appointments. That allowed the funding to be then repurposed for the visiting services, whether that was hot visiting or for the hot sites. I don't want to take any credit here. I'm very conscious that we've been working in an alliance, and there have been a number of reasons that have prevented the urgent treatment centres reopening. Some of them have been to do with operational issues. So, for example, the out-of-hours provider Vocare runs Westgate Road UTC, and there was an issue with them getting honorary contracts, so that we were pushing to open that one on the 19th of October. And we certainly, Anthony and I, pushed very strongly at the strategic meeting to get that opened. And there was a will and there was a willingness to engage, but unfortunately, there was an issue with honorary contracts. That's out with our control, because that is the only UTC that we don't manage. It's managed by another organisation. As well as that, there have been some issues because this is a GP-led service. So working with advanced nurse practitioners who are managing the injury side of things, and colleagues within the Alliance have made it clear to us that there are still some continuing issues with some advanced nurse practitioners shielding or not able to work into their sites. And so there have been some legacy issues around that. What I want to see is getting back to where we were before, which was to provide that joined up service and improve upon that. And we've been very grateful to have had the support of Yvonne Fraldy, who's been the manager for our service, working tirelessly from when she set it up onwards, to try and get those additional appointments back up and running. It is frustrating. I absolutely hear everybody's pain about why these services aren't there. In terms of the triage service, what we've done is we've doubled up triage GPs. So where there have been issues of social distancing and availability of estates, we've managed to double up with GPs so that they can take some of the telephone triage. And we are trying to get consistency so that all practices use the service and not just some of them. We're aware that there is real variation in terms of practices that use the service and some that don't. And we've tried really hard to make it as easy to access as possible. So what we've done is we've put reception-led triage. So it means that GPs aren't conducting that triage, because there's little point then, having done the telephone triage, to then put the patient into a UTC appointment. You might as well complete it yourself. So we've led the way in trying to release those appointments to practices, and we're also trying to reduce the amount of ledgers that are there. I hope that goes somewhere to answering your question.
You mentioned Molyneux.
Molyneux, we moved out of Molyneux in June at the request of the CCG in order to get Molyneux back up and running. And again, this is one of the difficulties of working within an alliance where you've got no control over other organisations. Molyneux still has not been able to deliver the UTC, and that sits with the executive of Newcastle Hospitals, and it is a frustration, particularly for the east of the city, where we clearly understand that those appointments need to be made available. Amy, does that address?
Yeah, I think it is just very frustrating. You just see all these GPs working those sessions, earning a lot more money than we potentially are in our sessions in practice, you know, with very good kind of like reduced patient contacts. I know it's a different way of working, but you just got to think a lot of the time it's just removing people from practice, general practice, where historically they would have worked in a practice. And I just never really understand that it really kind of helps us in a way, but maybe I just don't understand it.
No, I completely understand where you're coming from, and I think what we were trying to address at the outset was there was a significant number of GPs who were unable or unwilling for a variety of reasons, and these may have been because they had medical conditions, I don't know, who were precluded from working in a face-to-face context. So what we tried to do was to provide them with some additional resource by taking up telephone triage, and that was the original idea behind that. And that we implemented in March by sitting them alongside over at Regent Point. But I do think there is something about trying to get it on a more industrial scale so practices can actually feel that some of that pressure is coming off. And that's the work that we're pressing on at the moment. It's fair to say there are lots of complex reasons why that workforce isn't working into general practice. And what we were trying to do was to enable that workforce who were unable to do that work at face-to-face to actually contribute. So yeah,
that's fine, thanks.
No problem. There's a question from Tracy. Triage appointments have been blocked today at the triage service. Any idea why? Sorry, Tracy, I'll have to come back to you on that one. I don't know, is a simple answer. Shouldn't be blocked. I need to look at why that is.
Yeah, I went on tonight to try and book an appointment for someone, and when you actually look at it, there's quite a lot of red blocks in there. There were actually no appointments left for today. I'm not sure kind of where they've all disappeared to, but clearly if we're trying to provide a service for the city, we need to understand why those appointments are blocked out. Thank you.
Okay, I can certainly do that and have a look at that. Thank you. Deafening silence. We've either hit the spot or completely misread it. I don't know if there's any other questions that people would like to ask or not. Doesn't look like it.
No, just a reminder, the annual report will be released by Kate in the next few days. But thank you for listening, and thank you for all your ongoing support over the course of the year. And
just to re-emphasise that, you know, I'm very aware that this has been a grueling time for everybody, and it feels like we've gone through it and we've got it to face again, and we are committed, trust me, to do whatever we can as an organisation to support you at the coalface, and I really want you to please take that on board. We are absolutely committed to doing what we can, and we will shout from the rooftops wherever we can to provide that support. And I hope you can feel that there will be tangible support going forward. So, Rebecca, unless you've got anything to add?
No, ready for my tea.
Lovely. Okay, so thank you to everybody for joining us. Thanks, Kate, for facilitating this. Very grateful as ever for your engagement, and enjoy your tea and what else might go with it. A glass of something or a cup of tea, who knows. Thank you, everybody. Good night.
Bye.